use it. I'm sort of worked on the exercise, assuming that no one has read it. Which I understand. And I thought if we just put the abstract up rather than going through the slides, that we might get more out of it for use of combination. Who else do we expect to? Faculty from other departments is that the faculty feel that the academic mission of their lives is being diminished by the need to see patients. And I'm just saying, like yesterday, the Department of Neurology received 75 new outpatient consults. Okay, we cannot meet that in a week, and they're coming in at the rate of 75 a day right now. There are somewhere between 4 and 5 more referrals than times 400, 500% of what we can keep up with. I can tell you that a year ago, that number was 20%. And we see more patients now than we did a year ago. So the outpatient demand on our department has quadrupled in the last year. And I'm sure that's true for other departments, and I don't know what to say about it. I don't know what to say. I really don't know what to say.
Do we have a hard time to find faculty candidates, or Well, because we have very high standards.
So I have, right now, I interviewed 3 new faculty candidates in the last 2 days or something like that. And not one of them would come close to the people who are here. They don't come close.
You mean quality.
Quality, I sometimes use the word Menschkeit. And auf Deutsch, Menschkeit is Mensch is literally in German means man, but it's not used that way. It means a person in the Apache sense of the word. It means an individual who's a substantial person who cares and contributes and has things to contribute. That means this is a significant person. And Menschkeit means that they participate in those qualities of Menschkeit. And our faculty are a series of Mensches. And the people that I'm interviewing are not. They're just not. So on the other hand, the clinical demands are so great that I almost want to ask the question of whether we should be setting up practices, satellite practices for the departments away from the medical center, which just are more or less private practices. And a lot of the university, as I talk to the university chairs, we get together, AAM brings us together now semi-regularly. And that's a common topic, as they're saying, yeah, I mean, we can't keep up with the clinical. We just hire a bunch of doctors to buy practices. We go out and buy private practices and call them part of our department, and they see the patients. Because we can't possibly keep up with them. But a lot of our patients come here because we're not the first people that they're seeing. We're very often not the first people. And they come here because they've been elsewhere and they still have the same problem and it hasn't been addressed. All right. Anyway, so where we are. So where'd Maria go? I see. Okay, good. Hello, everybody. So, yeah. Right. We're waiting for Maria. Hi, all of you out there in viewer land. Great. Okay. Today's lecture is on variability and error, and and bias. Included in error is going to be bias. And I must say that I rewrote significant portions of this lecture last night and this morning. I think this is a little bit more challenging topic conceptually than some of the stuff we've been going over. So at any rate, at the end of this module, the idea is that we want you to know the difference between variability and error, and also the difference between random error and systematic error. And then what are the different types of bias that we encounter and what, if anything, is done to combat them. So this is sort of the intro for the whole talk here. Again, we're going to introduce variable and error, random and systematic. Here's your definitions. Random variability is inherent in measurement. It cannot be avoided. That's random. We're giving a name, random variability. Okay, we're naming it. And it's you take, and I encounter this all the time when I was doing research, and you're trying to measure very small amounts, maybe less than a milligram of a chemical, right? So you have these balances that are in rooms which are closed, all right? Because you can't have any draft, okay? And then you close the doors of the Mettler balance and you put the paper on the scale with a forceps. You don't even touch the paper because you don't want to get your oils on the paper, because the oils of your skin on the paper may weigh as much as what you're trying to measure. So you handle everything and you're trying to reduce variability. Nonetheless, you measure it 3 times and you get 3 different answers. Okay? That's variability. Those are things that are beyond your control. Okay? and no matter how many times you measure variability, you're still going to have the same variability. You can't just keep making more measurements, okay, in order to reduce the variability. The variability is inherent in the measurement. You take Zhao Yung and you put him on a scale, and the scale is capable of 1/100th of a kilogram, discrimination. And then you say, good, Zhao Yung, and you write it down. Then you say, get off the scale. Okay, Zhao Yung, get back on the scale. And you get a different number. Okay, that's variability. That's you don't understand why it happens. There's nothing that you can do to reduce it. That is random variability. Random error is a totally different thing. Okay, it's totally different. Random error results from sampling. Okay, I want to know the mean weight of men in the United States. Can I ever determine that number? This is an interesting question. This question is the type of question that a guy named E.T. Jain has asked. I recommended that book to you. So can you ever, I'm asking you, can you ever know the correct mean weight of all the men in the United States? Is it possible? Is it even theoretically possible to do that? How would you do it?
Measure everyone.
Okay. And how would you know if all the scales are precisely the same? How would you know that by the time that, can you measure them all simultaneously? No, it's going to take a month, right? If you wanted to have a national effort, right? Yeah, okay. You did stroke alert. You'd say measure every male on the same day. Okay. As people are stepping on and off the scales are starting to change. You're going to rebalance the scale for everyone. Do they eat lunch or they don't eat lunch? Is it before breakfast or after breakfast? Okay. Okay. So you don't do that, right? You never measure the entire population. Jane would argue that it isn't even theoretically possible. Okay. It's never going to happen. There is no truth in that sense. That's a logical statement by one of probably the major theoretical logician of the 20th century. Okay, so we're always sampling, and therefore, then the question is, how good a sample is it? Is the even if you could have a true mean, which you can, does the sample represent the true mean? So it's never going to be exactly the same, right? I say I'll measure all the people in New Jersey, okay? Or, it's like I can never get a really totally representative sample. So that inability to get the representative sample is called random error. That's the name given to it. Random error is different than random variability. Random error means a sampling error. It would be better if we called it a sampling error than a random error. But it's a random in the sense that it has to do with your sample. And you can reduce random error by increasing your sample size. You cannot reduce random variability by increasing your sample size. It's still just going to be variable. But you can reduce random error by increasing your sample size. Systematic error means that you're making a bad measurement. You've designed the experiment incorrectly. I talked, for instance, in a silly example, I said, we're taking the height of men and women with their shoes on. Okay? That's going to systematically introduce an error which is going to overestimate the height of women in comparison to the height of men because some women wear high heel shoes. Okay? That's a systematic error. I would be better off if I had everybody take their shoes off. Right? That would be a much better design. That's a systematic error, and we'll talk about that now. This is one of the things that I added overnight. So I think that this is a helpful diagram. It used to be that people talked about precision on one scale and accuracy on the other. But I think that that's probably not the best way of thinking about it, because accuracy is a combination of the better precision and improving correctness or trueness. This is a whole new idea, okay? So what do we mean? So here's what we want to get to. This is an accurate, it's like a target, okay? The guy is shooting into the target and he's very good and his gun is correctly aligned, right? Here's a person who's very good. He's a very accurate, he's very precise, okay? He can repeat his shot over and over again, but the scope is malaligned, okay? His sights are off. And no matter how many times he keeps shooting, he just keeps putting it in this narrow cluster off target, okay? He's gonna have to realign his scope, his sights. This person over here is not very precise at all, right? He's all over the place. He's simply not a very good shot. And so his gun is aligned because the mean is going to be right on the target. But he has a high degree of variability. So this shooter, okay, is very imprecise. And this person is both imprecise and his gun is malaligned, okay? His sights are off. His bias, so he's introducing a bias away from the center, and it's a big scatter. This guy has a scatter which is centered correctly on the target. This person has very little scatter, okay, but his gun sights are off, and this one is accurate. Okay, so this to go from here to here is improving precision. Okay, to go from here to here is reducing systematic error. Okay, you with me? Okay, this is random error. Okay, this is actually, so this is I don't know if that's random error or not. Let me take that out. This is definitely systematic error. All right. Just to say again what I've been saying now, random variability is inherent in the measurement. That is what you call your background noise. Okay, you can't reduce it. It is, as you say, you have no explanation for it. When you measure the single individual, you keep getting the variability. When you measure individuals within your group, you keep getting the error, and it cannot be avoided no matter what you do. And in an equation which is trying to deal with it, that's always written as plus epsilon. So all equations which have to do with error always include a plus epsilon at the end of the equation. That means this is the noise we can't get rid of, and it's there. And we're going to treat it, but we can't control it. We have no control over this, and so it's given us a symbol of epsilon. It's just all by itself. Random error is not random variability. It arises as sampling. Okay, you can't study the whole population, therefore you take a sample. The smaller the sample, the greater the likelihood by chance that the sample will not be representative of the population that you really care about. Okay, and the best thing that you can do with that is to increase your sample size, and that's going to reduce the likelihood that your sample population, that let's say the mean of that population, does not match the mean of the general population. The more people you put in, the more diverse your sample, okay, the closer you're going to get to the true mean, if there was such a thing. All right, and systematic error is now synonymous with bias. Okay, that's really the key here. This is, and you think of bias as, I think most of it, so in common speech, what is bias? What is bias? If I say, you're biased, what am I saying? I mean, what's the implication if I say, well, you're just biased? What do you? You're inclined to something. Yeah, so you're inclined to you have a subjective judgment, right, which is already skews your assessment of the situation. That's what we mean by bias, and in some sense, that's what's meant in the trial sense as well. But when we use it common language, we're saying you need to readjust your thinking. You're making some assumptions which are not justified, okay? When we use it in trial sense, we mean you could be doing this completely inadvertently, okay? You could not even realize that you're doing it. We're going to give you lots of examples. So bias does not mean bias in the sense of, I wish I was blinded. When the person is not blinded, they get the wrong error. These people could be fully blinded and still get the wrong error. Bias means that there's something about the way in which the trial was designed which pushes the result away from the correct answer, and it pushes it consistently away from the correct answer. So even if you increase your sample size, okay? And do everything that you can to minimize your variability in terms of reproducibility of measurements and standardization of your experimental techniques and clarity of definition, you're still going to get the wrong answer because the system includes a bias that pushes you in the wrong direction. That's what we mean by bias in a trial sense. I would say more often than not, it's inadvertent. It's not meant to be there. The investigators don't want it there. There are lots of different types of bias now that are introduced in trials, and these include things that we're going to talk about. Selection bias, misclassification bias, and confounding are the big three. You do not fix them by increasing sample size, all right? Selection and misclassification bias can only be addressed in study design. That is, there's no way to deal with it at the analytic stage. You can't go back and correct for it, okay? That's not possible. Confounding can be addressed during the analysis as long as you know what the bias is, which we'll come to because, frankly, most of the time you don't. If you knew that it was there, then you wouldn't let it in the first place. All right, so let's look at this. What is a selection bias? Well, a selection bias means exactly what it sounds like, and that is that the study population is not representative of the population that you care about, not just the general population, but not the population that you care about. All right. So again, I go back to some of the medical legal experience that I have. There was this hemorrhagic stroke project, which mostly occurred. The patient acquisition was in Ohio. Most of it was. And before the trial was fully designed, the investigators in Ohio went out and advertised this study. They wanted to recruit patients to it. And so they said, we're interested in people who took phenylpropanolamine and then had an intracerebral hemorrhage. Okay? And then the physicians of Ohio referred into the study the patients who had hemorrhage, right? Now, just think about it for a second. Do you think that they equally referred people with hemorrhage who did and did not use phenylpropanolamine? Do you think that their referral was going to be the same? No. So if you took phenylpropanolamine yesterday and here you are with a hemorrhage, okay? The average hemorrhage comes in and they go, would you take phenylpropanolamine? I don't know. Oh, maybe I'll register you, okay? But the one who took phenylpropanolamine, that was the whole point of the study, right? So they want to get that one into the study. So that's selection bias, okay? That's a great example of selection bias. They say the referrals were not population-based. They were selective according to some criteria which biased the study, okay? That's selection. Right, so when we're going to get to how you avoid this kind of bias, right? Misclassification bias we encountered yesterday or the day before when we were talking about observational studies. So misclassification can be either a misclassification of the exposure or of the outcome. So we're gonna look at misclassification bias in Parkinson's disease in a little bit, where the target of that study is family history of Parkinson's disease. Now, the patients who went into that study were examined. They were verified to have Parkinson's disease by a neurologist. So we're good, okay? The outcome was a family history, okay? Well, did a neurologist examine the patient's family? No. So that introduces the possibility of a misclassification bias, because now the question are patients capable of rendering an accurate family history with regard to Parkinson's disease, which is not addressed in this study? Okay, so that would be a misclassification for outcome, right? And we had other examples the other day. Misclassification for exposure, well, that would be an example of misclassification of exposure, because that was the family history. Right. Selection bias, all right, just what we've said, describes a selection of a study population not representative. Increasing the sample size doesn't help, and it can occur at several stages. It can occur mostly at recruitment. It can occur at follow-up. How would it occur at follow-up? Well, if you only count the people who come to follow-up, then are the people who drop out of the study the same as the people who finish the study? Probably not, is the answer. Probably not. People who drop out are different people altogether. They are, which group do you think is more compliant for medications? Right? The people who finish the study or the people who drop out of the study? Or you could turn it the other way around. Which group do you think is more likely to have had complications of their medications? People who finished the study or the people who dropped out of the study? Three, I'm not taking this medicine. I don't like it. Okay? They're not necessarily the same. So you can have that, and you can screw up an analysis easily by not being very smart. These are examples of selection bias. So I've already discussed with you referral bias, which is, I think, probably the biggest one. But survivor bias, okay, what does that mean? So here, look at this. It says you can recruit incident rather than prevalent cases, right? All right. So if I start with prevalent cases, what do I know about the time that they've had the disease? By definition, I know nothing, okay? This is just a prevalent case. This is someone who has the disease. Well, if he had the disease for 5 years, is he in the study? Yeah. What if he was diagnosed yesterday? Well, he's still in the study. Those are prevalent cases. So in terms of measuring survival in that population, it's going to be a mess, right? Because the people who die probably had the disease for a longer time. I mean, that's easy, right? So how do you counteract that? Would be, well, only recruit people who at the time of their initial diagnosis. And then I can start looking at factors which contribute to survival, okay, meaningfully. In a prevalence study, that makes no sense. Non-responder who stops in the survey, dropouts, that's what we're talking about. They're not the same, and that's the point. The consequences of selection bias are that you have a limited ability to generalize and that they're going to distort your results, and in particular, if one subgroup is different than the other. So that's just common sense then. That's selection bias. Misclassification we talked about, but I want to introduce, sometimes misclassification, by the way, is known as information bias because you make a mistake because you don't have the information. But this is you can have a non-differential misclassification and a differential misclassification. Non-differential misclassification means that you haven't been very precise at all in defining the outcome. And so it's sloppy. Therefore, it's going to increase variability. What will be the effect of that sloppiness on your ability to detect a difference between two study groups? Let me show you this way. Let's go to the board. So this is study group 1, data. All right. This is study group 2, data. Right? That's under really good. I don't have any misclassification error in here. All right. Now I start misclassifying everybody. Okay. What does the group look like? It looks like this. And what does this group look like? And what's my result going to be when I analyze the results? I lost the result. There's a difference here, but I was sloppy. I mean, that's the only term I can use is sloppy in your method because you increase the variability by having poor methods. Okay. So then a non-differential misclassification, simply due to sloppiness of your criteria, you're going to create a type 1 error. Type 2 error. So you're going to miss the difference that really exists simply because you're sloppy. On the other hand, if you have a differential misclassification, that is a subgroup, there's a certain subgroup, okay, which you consistently miss, and you miss it consistently in the wrong direction, you've introduced a new bias. And when you analyze the results, you're going to find a difference that isn't real. You created the difference because you misclassified a subset in the wrong direction. That's differential misclassification, so that inflates differences between groups. Examples of misclassification bias or recall, again, from the hemorrhagic stroke project, I use that example, and I said, did you take phenylpropanolamine in the last 2 weeks? And the people who had a hemorrhage remember everything about what came before, if they remember anything at all, okay? And the people, and then you go back and ask the same group, well, did you take 3 months ago, did you take phenylpropanolamine? And they go, yeah, get real, okay? In the hemorrhagic stroke project, which was just an awful thing, the interviewers knew the point of the study in the hemorrhagic stroke project. They knew that they were looking for phenylpropanolamine and that was the hypothesis of the study. They knew that, okay? No, you can't have that. Your interviewers, if you're going to do phone calls or in-person interviews, actually the interviewers should not know the point of the study, okay? They should just be going blind and going through the book and getting all the answers to the questions without regard to anything about the patient at all. And if they don't do that, then you run the risk of misclassification bias. Okay, and then clear definitions, okay, like I keep saying, you can't have sloppiness. Now I put this one in here. These are the easy ones, okay? Confounding is a much more difficult concept, I think. And confounding, the way I think about confounding is because of something that you do consistently, you introduce another factor which you weren't really aware of. And it's inadvertent, okay? And here's the thing, all right, is that, so first of all, confounding distorts everything. It completely distorts the results of every study. And this is what you do. For a confounder, for something to be a confounder, a couple things have to happen. Number one, it is associated with the outcome, all right? So the presence of the confounder is going to influence the severity or the likelihood of the disease. So the confounder matters. That's the first thing. The second thing is that the confounder is associated with the exposure, but not because of the exposure. Not because of the exposure. In other words, it isn't that when I give you this drug, this effect occurs and that affects the outcome, okay? No, it's I'm more likely to give you this drug because of this factor, and this factor changes the outcome. Okay, so this diagram I think is a very good diagram. All the other diagrams that I see I don't like at all. This is the relationship that we're looking at. We're trying to see if this exposure creates an event, a disease. The thing is that associated with this exposure, just associated with it for completely extraneous reasons to the point of my study, associated with the exposure is this confounding factor. And by God, this factor affects the outcome. But there's one more thing that has to happen for the confounder, okay? Does anyone see it? I'm going to let you breathe on it. Just think on this for a second. There's one other thing that has to be true in order for this to matter. So you see what the confounder is. But the question is, when does the confounding influence matter? When does it change the results of a trial? Yeah, but I mean, under what circumstances? I don't mean when was a bad question. Under what circumstances will the confounder affect the outcome of a trial? Outcome meaning to look at the comparison between the two groups.
That's really affect the disease.
No, it's going to affect the disease. That's its nature. If it's present, it will affect the disease, and it is associated with the exposure.
It's only
Say again.
if it's not related to both.
Correct. That's right. When the confounder is unequally distributed between the two groups, and that's why that association with the exposure has to be there. So if the confounder was present in both groups, then you wouldn't change. You wouldn't have a differential effect on the outcome between the two groups. This association is the key. All right. This is a current example, okay, where we wanted to know. For years we believed that thymectomy was important in inducing a remission in myasthenia gravis within 1 to 2 years, and that seemed one of the best established pieces of evidence that we had. There never had been a randomized controlled trial. It was always a cohort. There was good cohort data. The problem is that the people, since it wasn't randomized, the people who went to thymectomy, you didn't send an old man who was frail to thymectomy. Let me tell you, they wouldn't survive. We all knew that. So you didn't do that. Okay, the guy had to meet certain criteria before you'd let him go to thymectomy, which is an external splitting procedure. I mean, you're talking about a thoracotomy, so he has to be able to survive a thoracotomy. Okay, his myasthenia has to be at a certain level of control. His general health has to be at a certain level of control. If it's not, you can't send him to thymectomy. Okay, and so then the association. See how the arrow is drawn incorrectly? I would rather this arrow between the two. So mild disease obviously is going to make for a better outcome in myasthenia, and milder disease was associated with thymectomy. It wasn't caused by the thymectomy. The thymectomy did not give them mild disease. They had the mild disease, and therefore they went for thymectomy. So it's in the wrong direction. That's confounding. Okay. So it's distributed unequally between the groups. Now, if the confounding factor is known, and this is where it differs from selection bias or misclassification bias. Once you introduce selection bias, once you introduce misclassification bias, you're stuck. Okay, you can't get rid of it by analysis. Okay, but if there's confounding factor and you realize that it's a confounding factor, like severity of the disease, okay, then you can address that in the analytics stage. Okay, you can do a logistic regression analysis and with multivariate analysis, and you can also match people and propensity. So we're going to talk about restricting the inclusion criteria or matching subjects at enrollment. I'm going to talk about that in a second. But what is known, and we will talk at some point about propensity analysis. This is currently the most sophisticated way of addressing that, and that's a topic of its own. It deserves its own lecture. We'll get to it. You combat confounding. Now, here are some ways that you can do it. You can restrict or match. So let's say that let's stay with the example of thymectomy. Only let people who have mild disease into your cohort. Then the question is, well, why do you operate on some and not on the other if you're not? Of course, the answer to confounding is to do a randomized clinical trial. That will eliminate the confounding. It's the only way to eliminate it. But if you're not going to randomize it, if you're not doing a big randomized clinical trial, it's not practical. So then how do you do it? Well, you say, well, either at the recruitment stage or at the analysis phase, I'm only going to talk about mild people who, a good example is testosterone. Again, I'm from the legal literature. Men come in who are hypogonadal. They are all offered testosterone replacement therapy. Roughly a third of them say no. As far as we can tell, there's nothing different about them. They qualified for the testosterone replacement. It was their personal preference not to take it. Are they going to be the same as the men who agreed to take it? Well, no. I mean, there was something that said no. But as far as we could tell, they're the same. They have the same degree of hypogonadism. They were eligible to be treated. They had the same loss of libido, the same weight gain, the same, osteoporosis. Okay, so by looking at those groups, that will eliminate the TRT as a confounding, anything associated with TRT. It was, as far as we know, a random decision on their part. All right. You can deal with it in the analysis phase if it's known. You also can restrict it. You can just say at the time of enrollment, we're only letting a certain person in. So that's the end of today. So we have science requires measurement. You need to consider your sources of variability and error. Random variability is inherent. Random error is a result of sampling. The influence of random error can be reduced by increasing sample size. That is not true for variability. Systematic error is reduced by a flaw in the experimental design. It's not always easy to detect, let me tell you something, okay? And correcting it requires a change in your design. That's the only thing that you can do is change the design. Okay? I find this something that, well, first of all, we're going to return to these ideas multiple times now. I want to come to this set on the deconstruction with these questions. So if I should also put up the EBAS paper. All right, if I can, yeah, there it is. So let's just, let's look at this paper. All right, and let's just deal with the abstract. There's going to be information that we would need by looking in the methods section, but let's just start with the abstract. All right, Khaled, do you mind? Why don't you just take the objective? Just read that out loud and let's discuss what it is, okay?
To investigate a familiar aggregation of Parkinson's disease in a large collaborative population-based case control study.
Okay, so there's already like a ton of information just in this one sentence. So what's the experimental design? Is this observational or randomized? Yeah. So this is right. It's an observational case-controlled study. Okay. Where did they get their patients? How did they recruit patients into the study? What was the source of those patients? So it's population-based. So we don't know the precise answer of how they made it population-based, but this was not reproducing the error of the Ohio group, right? This is not referred by physicians. They're going out and by some large database, they're going to find these people and invite all of them to participate, everyone that they can identify. So that's population-based, all right? And what's the point of this study? Yeah. So basically, they want to know if family history of Parkinson's disease contributes to Parkinson's disease. Okay, that's the thing. This is a paper from 1999, and they're looking at epidemiology of Parkinson's disease, and they want to know how important is family history. That's what they're asking. Okay, so Eli, can you see the methods that they use then?
We included 219 prevalent cases of certain 3 European population centers using a 2-phase design consisting of screening and examination by a neurologist. Each case was matched by age, sex, and centered to 3 controls drawn from the same population, and 657. Presence of PD among first-degree relatives, parents, and siblings was determined using the family history approach for 175 cases and 481 controls.
Okay, all right. So again, a huge amount of information in this. So, all right, from this large population, the large collaborative, multiple population, they found a total of 219 prevalent cases. So these are prevalent cases, meaning necessarily we don't know how long they've had the disease.
Right.
Do we care? For this particular question, right, we really don't care, right? I mean, all we want to know is if they have a family history, whether they got the disease yesterday or whether they've had it for 25 years, it really doesn't matter to this question. So that's okay, all right? Using 3 population centers, they were large databases, as they say, in a 2-phase design. So they went and they looked like an ICD-9 code or something like that, a diagnosis of Parkinson's disease. They invited everybody with Parkinson's disease to participate. Whoever responded, now do you have bias at this stage? Yes, you have a responder bias, non-responder bias. So do they know, this would be important, do they know why the trial is being done? You better hope not, right? Because if you say, we're doing a study on family history of Parkinson's disease, do you want to participate?
Now, only
Look at
people
the
who have
selection by,
positive
so oh God, I have several family members who, yeah, I'm in, okay. I definitely want to be part of this one. No, I don't have anyone in my family. I'm not going to be part of this study. So obviously you would hope that they did not let anyone know why they're doing this study, right? And the interviewers too, right? Could you be part of the study? You want to be part of the study? Nobody, nobody in the family with Parkinson's disease, okay. All right, so that's the first thing. But then the second phase is they're actually examined by a neurologist. So you figure most of these people have Parkinson's disease of the 219. You think this is reasonable? You think do you think that we'll have a lot of misclassification bias of the study population?
If they don't use the same rating scale.
Yeah,
What is
so
movement specialism?
yeah, I mean that's true and the ability, but most neurologists can recognize Parkinson's disease. Okay, in 1999, probably we were misclassifying truth. A lot of PSP and a lot of multi-system atrophy. There's certainly that risk, and even I don't care who you took. If you took, what's his name, Home, and put him in front of a bunch of patients on one exam, he's going to miss some multi-system atrophy or Lewy body for Parkinson's. Say again?
Relative.
Yeah, so there's certainly risk of misclassification bias based on 99 standards. Actually, probably 15% of the patients were misclassified before. That in 1999, there were studies looking at that, and that's probably the answer. About 15% wrong. Okay, well, yeah, but at least they're Parkinsonian. I think we could agree that they're all 219 will be Parkinsonian. All right. Anyway. So that's a two-phase design. Each case is then matched by age, sex, and center. So this is often known as stratification, right? We're going to make sure that we have an equal number in certain age groups, right? We're going to make sure that we don't let men or women predominate in one group and not in the other group. They're going to be matched. All of our controls are going to have the same percentage, same proportion of male or female as our other. And we won't and we're going to make sure that our controls are reasonably drawn from the same center. That is, I don't want to get all the Parkinson's patients from Mannheim and all of my controls from Paris, right? I want the controls to be both from Mannheim and also from Paris in roughly the same proportion as the patients are, so that I have the same proportions. So that, okay, so that's matched. So that way, remember we said matching is one way to eliminate confounding. So we're not going to let the country of origin confound our result, because we're going to match our controls to our patients. So that's a good example. They're matching. That's what they're doing. And same thing for age and sex. All right. The control group is roughly 3 times the size of the, well, maybe precisely 3 times the size of the study group. Okay, that's all right. So we got a 3-to-1 case control ratio. Then we had the presence of Parkinson's among first-degree relative, mother, father, brother, sister. Okay. Now, 175 cases. So look at this number. So this is a little bit subtle, and you'll see it I'll show you the table that brought that to my attention. 175 out of 219, all right, produced good results. 481 over 657, all right? So in other words, take the ratio. So 175, right? 175 over, this is subtle, but I'm trying to get you to start to think about papers. 80% of the patients, of Parkinson's patients, we were able to get a family history, okay? Right. Now, among the controls, so we had 481 divided by 657, 73%. That's a pretty big number. So why weren't we able to, so there's something wrong about the control group here, right? There's something not the same. I don't know what it is, but there's something not the same about this control group, because that's a pretty big difference, okay? So I'm on the lookout. Let me jump to that table, which explains that actually, if I can. Here. The answer is here. No, it isn't. So I'll just tell you what the answer is. The answer is that they excluded demented people in that analysis for family history. So if the person was demented, right, the 175 are the non-demented Parkinson's patients, and the 481 is the non-demented controls. So there was a higher proportion of demented people in the control group, 27% versus 19%. So now there's something wrong. So we have a confounding factor. I don't know yet how I think that this influences the result, but I'm on the
I
alert.
don't understand why you said that.
They did. I don't know why either. I haven't reread this paper recently. Let me tell you, it's been busy. At any rate, but that's an observation that I made last night. All right, results. Maria, can you see the results, or come on around and read it? Shall we read it?
Overall, a positive
Yeah.
overall, a positive family history, at least one parent or sibling affected by TB, was reported in 10.3% of patients and 3.5% of controls. Odds ratio equals to 3.2 with 95% confidence interval.
All right, so stop for a second, okay? I want to emphasize what isn't obvious to you, but this is the way that these studies are all reported. The key word in that sentence, okay, to understand what comes next, the key word in the sentence that Maria just read is the word overall. Okay? In other words, everybody in the pool, okay? All subgroups. That's what the word overall means. It's among the whole two populations. I'm just comparing population A, Parkinson's patients, to population B, controls, at all ages, at all sexes, at all sites, at all everything. I don't care what's going on. Overall, this is the result. Okay? And the result happens to be that there's an odds ratio of 3.2. But I want to point out the word overall, because if you don't see that, then you miss the point of what they're saying. So, and you'll see that regularly. You'll see the word, some word equivalent to overall will be the first result. And you have to pay attention to it, okay? If you miss that, like I said, then you're wondering, what's the point of the next few sentences? And you're going, why is the numbers different in it? Because they're going to subgroups. So Maria, you can continue, please.
A similar association analysis of non-demented patients.
Okay, you see? So now they're doing a subgroup. And they're saying, among this subgroup, so in other words, whether the patients were demented or not demented, you get the same result.
But if they excluded already to begin with the demented patients to analyze the family history,
That's for us to decide. And yet they're saying, even when we did this differential, this is now a differential, an imbalance, right? Even when we kick out the demented patients in an imbalanced way, the overall, the result, the primary
using
result,
the same cascade of results they took from there, a subset,
right?
and now they took already demented and non-demented,
Right.
but excluding from the beginning.
So this is 1999. Don't you wish that you had figure 1 from the New England Journal, right? That goes like this, right? You see what I'm saying?
With the baseline
That's why that figure is so important. Okay, keep going. Right. Right. We found it.
Okay, we found a significant trend of increasing risk with number of affected relatives.
Stop. So, and we talked about this in the Bradford Hill criteria. So one of the Bradford Hill criteria was basically a gradient, okay, a dose response to the exposure, if you will. So they're saying, they're embedded in their thinking, and now, we're trying to teach you to read this stuff. And that statement is saying, look, we're trying to establish causation between a family history and the disease. Therefore, we're looking for a strength of association, a dose response curve, if you will, and we find it, okay? The more relatives with Parkinson's disease, that's the exposure, the more relatives, the more likely they are to have Parkinson's disease. Of course, it's a case control study. So it's actually, among the Parkinson's patients, there were more who had multiple family members. It's backward, but they switched it. They're not allowed to do that, but they did, because that's how we think. Okay? But strictly speaking, in a case control study, they should not have said that. And the reviewers should not have allowed them to say that, especially in the abstract. That is not correct. Okay, all right, but keep going.
Analysis stratified by age showed a stronger association for younger PD patients.
All right. So isn't that's now that I find interesting in terms of biology. That is, if you were to just divide Parkinson's patients into young patients and old patients, and you were to make, I said, which group do you think will have a stronger family history, the young or the old? The young, right? Old is just, well, there are going to be many, many more ways that they can get Parkinson's disease among the older. But among the young, for young to show up with Parkinson's disease, there's something wrong in their makeup, or they were exposed to some toxin early on, such as paraquat in Mexico. And okay, we could talk about another time. All right, but you're more, but so you like this? That is biologically plausible. And so you see they're addressing the Bradford Hill criteria. So okay, obviously their conclusion is that in this large sample of prevalent parts, so these I want to be clear, these authors are not trying to mislead you at all, are they? And you'll hear me say sometimes, you can do whatever you want in research as long as you say clearly what you did. And others may not like it, but at least if you say what you did, you're being honest. And they're trying to be honest. And so they're saying in this large sample of prevalent Parkinson's patients and population matched controls, the Parkinson's disease significantly aggregates in families. Now they're saying it correctly, okay, with the strength of the association being age dependent. Nice. Therefore, familial factors, which can be genetic, environmental, or both, play a role in Parkinson's disease. That's their conclusion. What's the primary weakness of this study, which we've already alluded to earlier? It is that a misclassification of the exposure. And so let's just look at this one slide and we're done, all right? Here, look at this slide. This is from another study. This has nothing to do with the study we just read, okay? A subsequent study in a different population compared the accuracy of family history of Parkinson's disease as reported by case controls for actual presence of affected relatives. In other words, seeing that potential flaw in this study, another group 4 years later went ahead and asked the question of how good is there potential for misclassification bias based on family history taken from the patient. And they asked that question precisely. That was the point of this report. And look at the answer. That's the sensitivity of a Parkinson, the sensitivity of the patient reporting a family history of Parkinson's disease was 65% for the Parkinson's patient, but only 45% for the control. So they went ahead and examined those people, okay? And they found a low sensitivity. If you didn't have Parkinson's disease, even if your family had Parkinson's disease in it, you didn't report it. It just wasn't that important for you. You may not even have realized it. If you had Parkinson's disease, you were much more likely to know that your parent had Parkinson's disease because you understood Parkinson's disease. You recognized it because you had it yourself, okay? The specificity actually is higher among the controls, but it's extremely high in either group. And so obviously then the net effect of this bias was to increase the odds ratio by a factor of 2. Now, does that mean that there isn't a role of family history? No. In fact, we were looking at odds ratios in the 3.5 to 8 range, depending on the subgroup. And even if you simple-mindedly cut those numbers in half and said, well, half of that, you got a factor of 2 here in the odds ratio and took 2 out and just literally divided the odds ratio by 2, all right? You're still somewhere between 1.5 and 4. Well, that was not correct. What I just did with a statistician would throw up. Nonetheless, it gives you a sense that there probably is, and this is often referred to by statisticians as a signal. You'll see the word signal, a word that I detest in medical legal consulting. A signal means that we haven't demonstrated it conclusively or even statistically significantly, but we sort of see it under the data. We see it there. We think that it might be there. That's a signal. I hate that. That is just It means nothing more than you have a hypothesis that hasn't been tested yet. That's what a signal means to me. It's the hypothesis. Okay? So good study to begin to tie together some of the stuff that we've been talking about. And that's it, we're done.
One question. Is
Sure.
Parkinson's disease rare enough?
Say that again.
Is Parkinson's disease rare enough to odds ratio estimate that?
So I hear this, I'm just not hearing. Is that it's rare enough to use what?
Because odds ratio is more accurate to estimate about
Is it,
yes, Parkinson's.
it's, so I would say Parkinson's disease is not rare. So it's incidence, its prevalence is 150 per 100,000. So that's a fairly big number. MS is 40 per 100,000. ALS prevalence is maybe 6 per 100,000. So Parkinson's disease is big. On the other hand, depression might be 20,000 per 100,000, right? So it's that's not its prevalence, but its prevalence is probably 10,000 per 150 per 100,000. So it's, but 150 is a pretty big number. Myasthenia would be 4 per 100,000. So,
Yeah. So the odds ratio generally also already overestimated.
yeah,
And then
right.
by that 2.3.
Yeah. Let me just take 1 second and look at what we're doing. So, session on Monday, right? I'm actually looking forward to these right now. These are, I think these, oh my God. I don't know what I'm going to do with this lecture. I looked at this last night. This is a real bear. This is basic stats. First of all, it covers a lot of stuff that we've already talked about, so it's redundant. And I can't decide where I want to go with it. This is a heterogeneous lecture. We talk about PICA, we talk about interval scales and those kinds of measurements, and then central tendency. This is going to be not only that. If you look how many slides, we've been working with slide sets of about 16 to 20. There are 80 slides in this talk. We're not getting through it. So I don't know what I'm going to do with this lecture. I just don't know right now.
You wanna?
I may cut a lot of it out because I think we've covered a lot of
Do
it.
you want to do maybe? Are you gonna be here Monday morning?
Mhm.
Instead of morning report, can we do half an hour of this
Um,
module 6?
We could probably do that. We could break that up. Yes, that'd help. I'll think about that. Yeah. Okay. Anyway,
Thank you.
I know you're all busy, so have a good weekend, everyone. I may change the talk to a talk on logic. I'm feeling right now that